Yeah, just a minute, sir. I'm making it.
Okay, okay. Loves. Okay. Yes. So live is showing, sir. Okay, na technical team. Can we start?
Sir, we are
Is it live? Okay, na? Okay, okay. Live is okay. Live is okay. Can I start? Sir, Arun Raj, sir.
Sir. Yes.
Start చేద్దామా సార్?
చేయొచ్చు.
Okay, sir. Introduce చేస్తాను సార్.
Okay.
Some attendees also is joining, sir. More than 10 to 12 attendees also joining, sir.
Okay.
Good evening, respected doctors. Welcome to today ECMA program. Thank you for all for joining us. Myself Ismail, and I will be your moderator for today's session, sir. It is my pleasure to welcome to our speaker, Arun Rajas, sir. DM Pulmonary Critical Care Sleep Medicine in Amara Hospital. Today, doctor will be speaking on SNTT. I hope everyone enjoys this informative session. Now, I request to Dr.
Can I start?
Yes, sir. Please go ahead, sir.
Yes, sir. Thank you for a kind introduction. So, good evening, everyone. Today we have an important topic. Today we'll be talking on SNTT, which is nothing but single nebulization triple therapy. So, going ahead, are my slides moving?
Yes, sir. Slides is visible, sir. Please go ahead, sir. Okay.
So I'll be covering this topic in broad details. First, I'll be telling about the burden of uncontrolled COPD, and then what are the challenges in the management of COPD, and then introducing what is SNTT, and then the recent trial which was published. So coming to the burden of the disease, the harsh reality, India is called the COPD capital of the world. So most of the patients who belong to COPD Gold B or Gold E, they are usually on LABA LAMA or your triple therapy combinations. However, despite all these treatment, 60% of the patients remain symptomatic. Because of even after usage of dual or triple therapy, they suffer from 2 to 3 exacerbations, and so this is the burden of disease in spite of usage of your triple therapies. So what are the current challenges in the management of COPD patients? So the first thing is, most of the patients with COPD, they have low peak inspiratory flow rate. So your peak inspiratory flow rate actually determines how good your drug is deposited in your lungs when you take it through a nebula inhaler or a rota cap. So most of the patients with COPD have suboptimal peak inspiratory flow rates. This leads to inadequate inspiratory effort and poor lung deposition. And second thing is, most of the patients have cognitive dysfunction and physical limitations because of their old age, and they don't have a good coordination between triggering the inhaler and taking the deep breath. Because of the weak fatigue, they are not able to take the inhaler which we prescribe. And because of all these things, because of multiple steps involved in using your inhaler or your rotacap, patients have high error rates with inhaler. So these are all the usual things which we see while managing patients with COPD who have an uncontrolled symptoms. So what is the solution for this? The solution is, we need a consistent, error prone, independent option ensuring sustained bronchodilation. So I'll be coming to the further what is the solution in the next slides. If you see a patient who has admitted with COPD exacerbation, he usually stays in ICU for 2 days, and then in the ward for another 5 days, and then post discharge, the follow up usually takes around 2 weeks for follow up. And if you see the recent Gold 2026 update, the recent 2026 update tells us that it is more in favor of using long acting bronchodilators whenever patient becomes stable. And this is what we are going to do. Increase dose and frequency with short acting bronchodilators to we are changing it to long acting bronchodilators as soon as patient becomes stable. So the Code 2026 guidelines also recommends this change. So what happens with repeated usage of your SABA or SAMA, the short acting beta agonist or the short acting muscarinic agonist? Usually in patients with severe V's, you prescribe it for second hourly or every 20 minutes in case of severe exacerbations. It increases the nursing load, and increased repeated exposures actually cause the beta 2 receptor desensitization, leading to decreased bronchodilation. So with higher doses, the response of bronchodilation diminishes. So this leads to limited bronchodilation with frequent usage. So what do we require? So what do we require is we require a combination which reducing frequent dosing and also which causes good bronchodilation. So the other current challenges which we face in ward are, if we use it for SABA or SAMA, if we use it for more than 48 to 72 hours, it despite stabilization, if we continue to use, then the patient's bronchodilation efforts will come down because of repeated usage. And some of the patients may be early switched to MDI, but because they had a severe exacerbation, their peak inspiratory flow rate will be very low and they will not be able to take the inhaler or the rotacap which you prescribe. And there is an option of nebulizer treatment also, but there is not a single therapy which is not available right now. You have to use either a LABA LAMA combination with an inhaled corticosteroid, leading to multiple drug usage. So all these things leads to delayed recovery and prolonged hospitalization. So the solution for this is we need a drug and a device combination which can offer an effort and an error independent sustained bronchodilation, which leads to continuation of care from ICU to discharge. So at the time of discharge, as I have said, triple therapy, many patients are discharged on dual therapy. Only some of the patients are discharged on triple therapy. And suboptimal discharge protocol, if you don't follow up the patients regularly, they have tendency for increased exacerbations. And if because of their low peak inspiratory flow rate, if you don't match the device according to their peak inspiratory flow rate, the chances of them using the device is very less. Even though you use the device, they don't have the sufficient bronchodilation. All these things leads to increased exacerbations and increased admission rates. So what do we require? We require an optimal device and drug combination which ensures good care post discharge. Also, you are sure that patient gets the drug which we have prescribed and he has sufficient bronchodilation, and the risk of him coming back to the hospital is very less. So that is what the solution we require. So just to summarize the slides which I have told, during the course of hospital stay and from ICU to ward to discharge and to the first follow up, we have all these things which I have discussed, all the things which are hindering the treatment. So the what is the only one solution which we need to know is an effort independent device ensuring optimal lung deposition with convenience, and which, if it is a triple therapy, the chances of recurrent exacerbations will also be very low. So the solution for both these things, all these things, is a single nebulization triple therapy treatment. So introducing the first, the Glenmark, they have introduced the first single nebulization triple therapy treatment. So the idea actually, it was first incidentally developed in December 2022. And then with this idea, whether this formulation is stability or not, they worked on it. In 2023, they have done some in vitro studies. They've taken the Indian experts validation. And in July, they have published the phase 3 protocol and they presented it to the DGCA, and subsequently they got the permission. And in October, they are actually into say. So introducing this molecule, formoterol budesonide plus glycopyrronium, the triple therapy smart respule. So it is called as a smartule. So each 2 ml respule contains a fixed dose combination of glycopyrronium 25 micrograms with formoterol 20 micrograms with budesonide of 0.5 mg. So what is the approved indication? It is approved for maintenance treatment of patients with chronic obstructive disease. So what is the usual dose which we prescribe? The usual dose which we prescribe is 1 Respule twice daily. So this is the DGCI approved letter. And coming to the in vitro drug deposition study of nebulized glycopyranum in COPD. So before going to the topic per se, before doing the in vitro study, what they did is they compared the triple therapy of glycopyranum, formoterol, budesonide with single therapy of nebulizer. So in reference 1 they have used formoterol, in reference 2 they have used the glycopyranum nebsmart G, and in reference there they have used the budecort nebulizer. And each these nebulizers they have compared the fixed dose combination SNTT regimen. So what they have observed is the delivered dose and the fine particle dose. The fine particle dose is the which is deposited in the lung. So the delivered dose and the fine particle dose of nebulized glycopyranum, formoterol, budesonide demonstrated a comparable drug deposition profile when compared to individual components. So within the 15% of range, the bioequivalence limits were there. So even if you use single formoterol, compare it with the triple therapy, the drug deposition was almost same. So coming to the phase 3 evidence, this is the Indian evidence. They have actually compared, this is a very good study which they have done. They compared the nebulized glycopyranum with MDI of glycopyranum. This was a randomized, double-blind, double-dummy clinical trial, in which they used to assess the efficacy and safety of fixed-dose combination of glycopyranum, formoterol, budesonide inhalation in comparison with same formoterol, glycopyranum, budesonide as an MDI in patients with COPD. So the total study population was 314 with their mean age of 58. Most of them were male, and most of the patients had severe COPD. They are gold severe grade 3 category, 61%, and rest of them were moderate grade. And the dyspnea severity scores, most of them had a severe dyspnea severity score, more than 2 were more. 70% had severe dyspnea. Coming to the eligibility criteria for the study, so patients with a diagnosis of COPD. So how do you diagnose COPD? The FEV1 by FVC post bronchodilator value must be less than 70%, and the post bronchodilator FEV1 should be more than 30% predicted, and it should be less than 80% predicted at the screening visit. This was the inclusion criteria they have used. The FEV1 should be more than 30 and it should be less than 80. And patients who had severe exacerbations, more than 2 moderate exacerbations or 1 exacerbation of COPD leading to hospitalization, they were included. Subjects who are on LABA-LAMA or LABA-ICS or LAMA were included, and the baseline eosinophil count in these patients should be more than 300. The exclusion criteria was patients with asthma and patients already on triple therapy, they were excluded actually. So they are randomized into 1:1 fashion, and they were followed up for 2 weeks. So the first arm received nebulization glycopyranum using JEP nebulizer, 157 of the patients. And the second arm received MDI, same combination of glycopyranum, formoterol, and budesonide, 2 puffs twice daily. That also included 157 patients. So after the end of the study, they were followed up for 1 week. So this was a multi-center, randomized, double-blind, double-dummy, parallel group, non-inferiority study. Mind this is a non-inferiority study. So the primary efficacy was change in baseline in the trough FEV1 at week 12. So they compare the baseline to the 12th week FEV1 in both the groups. It had multiple secondary endpoints, and some of the secondary endpoints were change in the FEV1 at week 4 and week 8. Another secondary endpoint was change in the baseline FEV1 at 12 weeks after 2 hours post dose, and number of rescue medication usage. And it also compared the change in the baseline FVC to 12 weeks FVC, and also change from baseline MMRC to 12 weeks MMRC. So it also had a safety endpoints like treatment emergent adverse events were noted, frequency of exacerbations were noted, vital signs, ECG parameters, lab parameters, and everything was recorded. And if you see the primary endpoint was met with a non-inferiority margin of 80 ml. If you see the orange curve, it is the nebulized glycopyranum group, and the red curve, it is the MDI glycopyranum formoterol budesonide group. At 12 weeks, actually, patients had a non-inferiority margin of 80 ml. And if you see the mean change in baseline, change from baseline in 2 hours post dose FE1. So the orange group represents the nebulized group and the red group represents the MDI group. So there was a statistically significant difference between both the groups at initial 2 hours post FE1. If you give the drug, and after 2 hours, if you see the FE1, there was a significant difference in the patients who had received nebulization. And the same was also seen in the week 12. So this was persistent even after 12 weeks. So there was a numerically larger improvement in 2 hours post FE1 at 12 weeks in the nebulization group when compared to the MDI group. And if you see the mean change from baseline in the MMRC scores, the orange represents the nebulized group and the red represents the MDI group. Both of them use the same triple therapy combination. If you see, there was a statistically significant difference between the MMRC. The MMRC grade decreased actually in patients who had nebulization. There was a superior improvement in the MMRC scores when you have used nebulized glycopyranum when compared to the MDI triple therapy. So there was greater reduction in the MMRC, superior relief in dyspnea. And coming to the rescue medication use, the patients who are on nebulized SNTT when compared to the MDI SITT, so patients who had received a nebulized SNTT had significant reduction in rescue medication usage. And compared to the baseline FVC and the 12 weeks FVC, patients who are on nebulized SNTT, they had a significant improvement at week 12. Are my slides moving?
Yes, sir. Yes, slides
Okay.
moving. Yes, sir. Yes, sir. Please.
Okay. So the most common treatment emergent side effects were very low actually in both the groups. The most common were only mild things. There are no moderate or severe things which were reported in both the groups. Most common things being some mild cough, URTA symptoms, pyrexia. And important to remember that the COPD exacerbations, both of them had similar exacerbations, 2 exacerbations in both the groups. Overall, there are 4 exacerbations. I'll be coming into the details in the next slide. The overall 4 exacerbations episodes were reported, though 2 were mild and in the nebulized triple therapy group, and 2 patients in the MDI SITT group. One had a moderate exacerbation, and majority of the exacerbations were mild intensity in the nebulized triple therapy group, and biochemistry and hematological values were normal in both the groups, and majority of the patients had normal vitals at both baseline and also at 12 weeks. There was no meaningful differences in the vitals. And coming to the ECG changes, both the groups did not demonstrate any significant ECG changes when compared to baseline and 12 weeks. So nebulized triple therapy glycopyranum formoterol budesonide, it demonstrated a favorable and comparable safety profile when compared to your MDI triple therapy, with no new safety concerns or clinically meaningful changes were observed. So just to summarize, the primary endpoint was met. The non-inferiority margin of 80 ml was met when compared to both the groups of FE1 change, and it improved the lung baseline lung function at 4 weeks, 8 weeks, and 12 weeks. And also there was sustained improvement in the FVC, and also MMRC scores were very low. And 2 hours after drug delivery, there was a significant change in the FE1, meaning that the patients who had taken this nebulizer had improved lung function. There was a superior 2 hours post dose FE1 on day 1 versus MDI. There was less rescue medication usage, and the safety profile was comparable, and there were no major adverse side effects with the usage of this new drug. So with this after the completion of the trial, the approval was taken, and each ml actually contains 25 micrograms of glycopyrronium, 20 micrograms of formoterol, and zero 0.5 mg of budesonide. So this is usually recommended for patients who are on maintenance therapy for home nebulizations with COPD post discharge. So one of the important things to discuss is why nebulization and why not we can give an inhaler to patients who. So these are the Indian guidelines which have been recommending home nebulizations for patients. So it is important to remember that in patients who have cognitive impairment because of their old age and comorbidities, they will not be able to use the inhaler or the rotacap which you prescribe, and reduced manual dexterity because of their weakness or fatigue, they will not be able to take the inhaler. And patients with muscle weakness or pain, neuromuscular incoordination, they also will not be able to take the inhaler or the rotacap which you prescribe. Patients unable to use any handheld inhaler because in spite of the repeated instructions and counseling, there are at least 20% of patients in clinical practice who will be not be able to use any device. And patients, as I told earlier, patients with severe COPD, they have low peak inspiratory flow rate, and they will not be able to trigger the inhaler and have good drug deposition. And patients who have inadequately controlled and who need higher doses of medications, so these are all the patients who require a nebulization therapy. So nebulization is the preferred choice of patients in COPD patients. What it usually gives is the comfort and confidence at home. Nebulization makes the patients feel more comfort and comfortable because they're able to take the drug, and we are also safe that patient has taken the drug. We are also sure that the deposition is good because the patient has taken it through nebulizer, and it causes better symptomatic relief. 75% of patients reported greater symptomatic relief with nebulizers than inhalers, and greater adoption among patients who are severely symptomatic. So patients who have severe MMRC scores, they actually benefit from the usage of nebulizers rather than your inhalers or rotacaps. And strong patient and caregiver preference. 80% of the patients and caregivers also, because they need to see whether the patient is taking the nebulizer inhaler or the rotacap which you prescribe. With the nebulizer, if you train the patient, they can easily just attach the nebulizer, switch on the machine, it will actually deliver the drug. So caregivers also, they have preference to use nebulizer. So coming to the evidence regarding the triple therapy, so these are the published trials in various blue journals. If you see, most of the patients who are on triple therapy, the change in baseline to trough FE1 was significantly better in patients who have used triple therapy. And it also it was also seen that patients who are on triple therapy, they had significantly reduced exacerbations. And coming to the evidence in the exacerbation management, so these are the two abstracts which have been published in CHEST 2021 and CHEST 2023. In CHEST 20, they actually prescribed that long-acting bronchodilator nebulization can be a potential alternative clinical strategy for management of hospitalized patients with acute exacerbation. And CHEST 2023 also, they prescribed that in hospitalized patients, a long-acting regimen of can be substituted. So these are all the evidences regarding the usage in acute exacerbation. Oh, we also have an Indian study which was published in Lung India. So here actually, with 120 physicians across India were invited to participate in this survey with 10 questionnaires on the preference of therapy in acute exacerbation. And out of the 120 physicians, 101 physicians participated, and almost half of the participants preferred nebulized therapy of triple therapy based combinations in emergency and ICU, and majority of them preferred nebulized glycopyrronium based triple therapy in ward one stable, 60% of them, and 43% of them preferred nebulized glycopyrronium based triple therapy at discharges for home nebulization also. And rapid and sustained effect of nebulized glycopyrronium triple therapy makes it an emerging choice among physicians with up with acute exacerbations, especially in severe cases. And it is also important to remember that earlier initiation of nebulized glycopyridine combination and its continuation till discharge indicates its full utility in transition of care. So the earlier you start and patients once they get discharged, you just need to continue these drugs so that you can ensure a good bronchodilation occurs, and subsequently the chances of patients coming back with severe exacerbations are very low. So, what are the proposed clinical profiles in COPD continuum of care? So, in long term maintenance therapy, symptomatic high risk patients, even if you prescribe maximum inhalers, they still have symptoms. And patients who have cognitive impairment, patients who have neuromuscular incoordination, patients who have suboptimal peak inspiratory flow rates, and who are unable to use the inhaler or the rotacahelars, they are actually the long term maintenance therapy. You can prescribe SNTT combination for all these patients, nebulized glycopyridine, formoterol, budesonide. And for early initiation and faster stabilization, so in patients who are presenting to the emergency, you start with Sabasama, and once the frequency reduces and once the patient stabilizes, for sustained bronchodilation, always prescribe a add-on therapy of long-acting beta agonist, long-acting muscarinic agonist with budesonide. And in patients who are in ward and at discharges and in follow-up, for seamless transition from hospital to home, always try to prescribe a nebulized triple therapy so that the chances of the patients are very easy to take it at home, and the chances of them coming back with severe exacerbations is significantly decreased if you prescribe in ward and at discharges and during follow-up also. So the key takeaways are multiple challenges still exist in overall COPD continuation of care, and inadequate therapy and incorrect choice of disease significantly impact the treatment outcomes, as I have told earlier. So nebulization is one of the important things which do not require coordination of actuation, that is the activating the inhaler and inhalation or an inspiratory flow threshold, promising a sustained alternative in high risk patients. So in high risk patients, because of all these things which they have difficulty in coordinating breath and taking in, nebulization perform delivering drugs through nebulization is an important thing which will actually decrease all these things. And SNTT, as I've said, combination of nebulized glycopyridine, formoterol, and budesonide has shown to be non-inferior to your similar therapy with MDI. And actually it has non-inferior, but there are a lot of superior things, like it reduces the rescue medication usage, it increases the 2 hours post FE1 deposition, and it also increases your FVC, and there was a sustained improvement at 4 weeks, 8 weeks, and 12 weeks. So though this is a non-inferiority study design, the SNTT actually has significant advantages when you're transitioning care from ER to ICU to ward, or from ward to hospital discharge, and for chronic maintenance of patients who have cognitive dysfunction and who are not able to take inhalers and who are having persistent symptoms despite maximum therapy with your MDI or rotacaps. So these are all the ideal candidates in which you should continue or you should start initiating SNTT. And growing evidence of early adoption of triple therapy early in exacerbation management, it significantly improves the overall treatment outcomes. Thank you for your patient hearing.
Yes, yes, sir. Thank you, sir, for your valuable presentation, sir. Please hold, sir, 10 minutes, sir. Some questions answer also. Question answer is there, sir.
Okay.
Dear doctors, please post your questions. Ready. Please wait, sir. 1 minute, sir.
Okay.
Hello, sir. Hello. Sir, I'm
Hello.
audible.
Hello. Yes, audible, sir. Technical team.
Yeah.
Please hold. Some questions questions answer session is
Okay.
there. 10 minutes.
Okay.
Please hold.
Okay.
Okay, sir, Arun sir. Some
Yes.
yes. Some attendees also sharing some posting some questions, sir.
Okay.
Can you start, sir?
Yes.
Okay. Sir, your video is not visible, sir.
Okay.
Camera is not visible. Sir. Yes. Thank you,
Okay.
sir. Sir, starting. Sir, dear doctor, in which COPD patient do you prefer initiating SNTT?
Usually for severe COPD patients who had COPD-E actually, and also if patients who are B also COPD-B also, if they are unable to take the prescribed treatment, I usually start off with SNTT. And patients definitely during discharge with severe exacerbation or a mild to moderate exacerbation, always prefer in the initial phase of management, you always initiate SNTT. I hope I am clear.
Yes, sir, exactly, sir. One more question says came, sir.
Okay.
Dear sir, what are the common challenges you face while managing severe COPD patients?
So, as I have told, the severe COPD patients, so one of the things is exacerbation is one of the most common cause for the decreased lung function. So, all our efforts should be to decrease the exacerbation. That is the first thing. The one thing is the cost issue because of this, but right now, probably all the drugs have been coming down, and so one of the thing is compliance. Patients don't take the inhalers which we prescribe, so one thing is you ensure compliance, and even if you prescribe a nebulized therapy, there are multiple nebulizers he has to use. One morning, night. That will be very difficult for the patient. So now that we have a single nebulized triple therapy, which has all the components and which has all the beneficial effects of both all the drugs, so probably it will revolutionize the management in COPD patients.
Yes, sir. Yes. One more, sir. Dear sir, for your day-to-day practice, in which patients benefit more from nebulizer therapy compared to inhalers in your clinical practice?
Okay. So, in patients who have persistent symptoms despite usage of your maximum dose of inhaler, even if you prescribe maximum dose of inhaler, patient is having persistent symptoms, always try a nebulized therapy, probably a triple therapy, which will be helpful. And for old age patients, for patients who have muscle weakness, who have weakness of CVA, right hand weakness, and patients whose peak inspiratory flow rate is very low because of recurrent exacerbations, and patients who are unable to activate the inhaler and take a deep breath because of this weakness, or they have some incoordination between activation of the inhaler and taking the deep breath. So these patients, usually old age, cognitive impairment patients, these are the patients usually we prescribe nebulized therapy.
Okay, sir. Okay, sir. One more question, sir. Asking, sir, what factors influence your decision to choose nebulizer triple therapy?
Okay, this is a good question actually. So the factors which influence me to choose nebulized triple therapy are so what, how many exacerbations the patient had previously, and how well controlled is his symptoms. So these are the things which we need to see before initiating on nebulized triple therapy. If the patient is well controlled and if he is using his inhaler or rotacap regularly, and if he has no symptoms, then there is no point in initiating a triple therapy. In patients who have recurrent exacerbations despite usage of triple therapy inhalers, these are the patients in which we think about initiating a nebulized triple therapy combination device. And also, if you are using a budesonide, always check the blood eosinophil levels. Even in this trial, also the patients who had a blood eosinophil levels more than 300, they were included. So all the patients who had blood eosinophils levels more than 300, they actually fit in the criteria to include a inhaled corticosteroid, either in the form of a nebulization or an MDI, for patients who have recurrent exacerbations despite optimal management.
Yes, sir. Clearly, sir. Okay. One more question, sir. Some other attendees also share your question, sir.
Okay.
Dear sir, have you observed better symptom control with SNTT? Could you share your experience?
Yes, recently only we have started prescribing this medication. Actually, 2 weeks ago we had a patient with severe exacerbation, and he has been repeatedly admitted. Once in 3 months he comes regularly, and I've started him on the SNTT last month ago, and probably I have not till now he has not returned back. Probably I'm hoping that he is having well good symptom control. So that is my experience. Patients who are having severe exacerbations with needing recurrent exacerbations and needing hospital visits, after starting triple therapy with SNTT, they had good symptom control.
Okay, sir. Okay. So one more question is came, sir. Uh, Sir, in which patients group show the highest compliance with nebulizer therapy?
Okay. Usually the group who have severe exacerbations like A, B, E, if you prescribe in E group, they usually have the beneficial effects are very high, and the compliance was also very high with them, because this is a very easy method, only one respule once in the morning and once at night evening. So this is very useful, and they are usually compliant with it. The E group actually has better compliance and better results with this new drug.
Okay, sir. Okay. Sir. One more question, sir. Maintenance. Okay. Sir, do you use SNTT during acute exacerbations at discharge or for long-term maintenance?
See, the role of SNTT is very clear. In patients who are on long term maintenance, you can substitute an SNTT. And in patients who had a severe exacerbation, who are on nebulization and you're transitioning to home care, always prescribe an SNTT. And in patients who are in ICU with severe exacerbations, to decrease the usage of SABA and SAMA, because you have to keep them regularly, long term. The risk of toxicity with SABA and SAMA is also very high, and they provide shorter bronchodilation. We always add an SNTT to ensure longer bronchodilation. So SNTT is actually used in all these settings. It is useful when you discharge the patient. It is useful in acute exacerbations. It is also useful in stable patients for home nebulization therapy for maintenance also. So all these three scenarios you can use SNTT.
Yes, yes. Okay. Sir, what clinical improvement do you use observe after starting SNTT?
The main thing is patient symptoms. The dyspnea comes down, and the beautiful thing is the risk of exacerbations comes down. For patients who have you have been seeing repeatedly because of exacerbations, they don't come back to you, meaning they are good controlled, well controlled. The dyspnea also comes down. Patients actually tell us that after taking this nebulizer once in the morning and once at night, now my breathlessness is reduced and I feel more energetic. So this is what the patients tell us. The dyspnea and the exacerbations, both of them come down.
Yes, sir. Yes. Sir, one more question, sir. Sir, which type of COPD patient would you not consider for SNTT?
Usually the COPD A group, which usually have mild symptoms and mild exacerbations, they can usually be managed on a single inhaler therapy like a LABA, LAMA, or a combination of LABA, LAMA. So in these patients, we usually do not recommend SNTT. These are only the COPD A patients, the mild group. But in India, the chances of you finding a COPD is very rare. We usually see most advanced COPD who have moderate to severe exacerbations. So these are the group we usually cater to. So in India, the chance of finding a COPD-A is very rare, and SNDT is usually not recommended in patients who have mild disease or COPD-A.
Yes, sir. One more, sir. Sir, based on your experience, what is the biggest advantage of SNTT
So
over
the
conventional inhaler-based triple therapy?
So the biggest advantage is the compliance. If I ask the patient to take an inhaler twice, two puffs, once in the morning and two puffs in the night, if I use an MDA with a spacer, he has to attach the spacer. Someone should sit with the patient, train them, and also someone should ensure that he has taken correctly. Like he should press the inhaler correctly, he should time the breath correctly, and he should inhale deeply, and he should hold it for 10 seconds at least. So this is a very cumbersome process for patients who are poor or uneducated people. They have very difficulty in taking these inhalers because of their response and their coordination efforts. And sometimes there will be no patient attenders also who will help them to know the technique. So the biggest advantage with SNTT is now that we have all the three drugs in one combination, you can just prescribe one Respill once in the morning and once at night. The patient only needs to buy a nebulizer, take a oxygen mask or a jet nebulizer mask, pour the drug, switch on the machine, sit for 20 minutes, and that's it. So it will ensure that the drug is delivered correctly and there is no chance of going wrong. So patients will have sustained bronchodilation also, because they are long acting and they work for 12 to at least 24 to 36 hours also. They have sustained bronchodilation, and patients will have less symptoms of dyspnea. So in my experience, the two things which are most important with this is, one is compliance because of all the drugs in one, easiness to use with nebulizer, and the second thing is very good response in decreasing the symptoms of dyspnea, and third thing is decreasing the exacerbation rates.
One more, sir. Sir, present in the market is Lama is separate, ISIS Lama is separate. Both mixing together, we given to 4 ml, na, sir. Still, SNTT is came from 2 ml. What is the exact difference from 4 ml versus 2 ml, sir?
I did not get your question. What is the difference between?
Okay. In this current market, glycopenum is separate 2 ml.
Yes.
Pharmacopolisonol combination 2 ml.
Yes.
Both mixing together 4 ml.
Yes.
But the SNTT is came from 2 ml.
Yes.
What is the 4 ml versus 2 ml, sir? What is your opinion, sir, practically?
Practically, 4 ml versus 2 ml, probably they have decreased. The amount of drug must be increased in the concentrate. That's what my understanding is. The amount of drug, if the in the 2 ml concentrate should be like compared to the 4 ml, they should be increased. That is what my understanding is. Any inputs from your side on this?
Yes, actually, some technical scientific session also is there, sir. This is a 4 ml is a glycopenum is should still market in solution
Okay.
form, sir. So SNT form, SNTT after is the suspension form,
Yes.
the glycopen. That is the glycopenum suspension, pharmacopolisonol both mixing together suspension
Yes.
form, sir. So you have the technology, the homogeneous technology used to this SNTT, sir. So that's why the mixed together is a patented technology. We given to 2 ml, sir. And also also very saving, sir, and also the sister
Yes,
workload
yes.
also
Will
very
be difficult to take a 4 ml. It will
in
take
the,
at least 20 to 30 minutes. With 2 ml, it's roughly around
yes,
5 to 10 minutes. It will be over.
exactly 8 to 10 minutes
Yes.
also you have a very time schedule also. This is very comfortable to patients, sir. That's asking the other audience also asking this much of questions, sir.
Yeah.
4 ml versus 2 ml, what is the
Yes.
efforts also? Because of glycopenum in other is a solution form, given
This
to
is a
the
suspension
particle size
form which
also.
is patented.
Yes, it's present in SNTT is the suspension form, sir. That is
Okay.
why easiest deposition of this is our paint, sir.
Okay.
Okay. Okay. One more question is came, sir. Sir, presently, launching in other companies like Review Finance in inhalation solutions.
Yes. Yes.
What is the difference? What is the major difference like glycopenum versus rifampicin? What is your practical day-to-day practice?
See, rifampicin is yet to launch in India probably, and rifampicin actually has one advantage when compared to glycopyrronium is it has a more M3 activity. So sustained bronchodilation is what they tell, and the dosage of rifampicin is 175 mg, one respule per day. This when compared to glycopyrronium, actually we should use and see. Probably it is yet to launch in India. Probably in the next month or so. Probably we'll be getting, and it is probably not studied for acute exacerbations as glycopyrronium was studied. That is what my understanding is, and there are also not much data on continued home-based nebulizations and transition from hospital to discharge. So there is not much of data. It is only usually used for chronic maintenance therapy for stable patients. For rifampicin, as one advantage is it's once a dosage, and it is more M3 receptor activity. So sustained bronchodilation than glycopyrronium. That is the only one advantage which I can think of. But we have to still use it here and see how it, because Indian population is completely different when compared to the studies which are done in the western side. So I'm just waiting for the molecule.
Some okay, sir. Some all questions is closer. Uh, 1 minute, sir. Maximum. Every question also you have patience you have given to clear-cut communication given to our audience, sir. Very helpful for viewers. Valuable feedback, sir. Please hold 1 minute, sir. Yes, sir. The complete questions also not came, sir. All questions also clear, sir. Sir, okay, sir. Thank you for doctor for your valuable presentation, sir.
Last but
And
not the least, I would like to thank the Glenmark team for giving me this opportunity. Thank you.
today's session is very useful for us, sir. And thank you for all represented all other attendees, doctors, sir, joining for the participation in today's ECME program. 1 minute. Echo is okay. 1 minute, sir. Some technical team also will take.
Okay.
Okay. Please, technical team, please respond. Hello. Hello, technical team. Hello. Hello, technical team, please respond. 1 minute. Sir, Arun sir, మీరు లాగౌట్ అవ్వండి సార్. నేను టెక్నికల్ టీం నేను మాట్లాడుకుంటాను. థ్యాంక్ యూ
Thank
సార్.
you.
థ్యాంక్ యూ. హలో, టెక్నికల్ టీం. హలో. హలో, టెక్నికల్ టీం. హలో. 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 హలో.
हेलो सर, जो कॉमर्शियल करने का
लेकिन उल्टी और थाई
हेलो।
में पश्चिम जो है
ये जो
मतलब अच्छे से छोड़ दीजिए ना
वो
हम
बोल
क्या
रहा है
देखिए
कि ना डॉक्टर ने ऑलरेडी फीस से
हेलो।
ज्वाइन
अपने सामने तो
हेलो सर, जो कॉमर्शियल करने का